Welcome. Welcome to this interesting session that is dedicated to PCI in calcified left main stenosis. Again, Adrian, again calcium. There's nothing else than calcium in this EuroPCR. So it means that this topic is quite interesting, and from the number of colleagues here in the room, it's going to be also, we hope, a very interactive discussion. We're here for a tools and techniques session, so it will be a very practical session. We'll try to highlight the best use of each tool and techniques that we are going to see and discuss together. Let me start doing my duty, thanking the sponsor, Boston Scientific, that made this session possible. And after having said that, I will go to the reason why we are here. Let's see if it works. Okay, that's me. Oops, next. Oh, too much. Yes. I think if we are here is because we want to understand more about the importance of intravascular imaging to guide left main percutaneous coronary intervention. So we already know where we are heading to. We're heading to discuss about imaging, specifically in this important lesion setting. We would like to learn more on how to safely and effectively adopt advanced plaque modification tools and techniques. And we want to appraise the proper stent selection, tailored stenting technique to target left main stenosis. This is now the mission we have. How do we achieve this mission? With excellent colleagues. Valeria Paradis is co-chairing with me this session. Discussants, Adrian Benning. I don't think he needs introduction, much like Darshan Doshi, our discussants. We have two operators, so you already understand we have selected a very nice recorded case from St. George's Hospital in London, done by James Bratt and Claudia Cosgrove. And I hand over the word to Valeria, that has a very important communication here.
Thank you very much, Emanuele. So we're here indeed to discuss this important topic, but we also want to interact with you. So please share your questions and comments. You can use actually two methods. You can just walk to the microphones. You can see them at the side of the room, or you can just send your questions via the chat box. So we will have dedicated time for discussion after each presentation.
So really, you have no excuse not to interact. So if you are lazy enough not to take a microphone, you have your phone, send the questions in. Emanuele is there, and he will share the questions with all of us. I think we need to address now the first problem that we have today, namely why intravascular imaging guidance, and I look to Adrian, is key to achieve an optimal procedural success in general, and to Adrian we'll ask more in particular in left main with calcified lesions. Adrian, please.
Emanuele, colleagues, thank you very much for the invitation to present today. My task is to ask you all why you're not using imaging and to challenge you really with the data that we have. So what will imaging show me in my routine PCI practice? It'll help me size, it'll show me what the lesion is like that I'm treating, and it can even tell me whether the lesion is significant. During the intervention, it can tell me whether the stent is apposed, whether it's optimally dilated, whether I've put it in the right place, whether there is dissection. And of course, there are special subsets where imaging could be considered as mandatory, particularly in stent restenosis, and I would contend probably the left main. What data is there out there that intravascular ultrasound is helpful? Well, actually, there's quite a lot of data. This data comes from a study of 8,500 patients where 3,000 were randomized to intravascular ultrasound. And you can see the impact here on stent thrombosis and myocardial infarction, IVUS usage in yellow, no IVUS in red. These data are supplemented by the XPL trial of 1,400 patients randomized to intravascular ultrasound or angiography. And as you see, an impact on hard outcomes of intravascular ultrasound. And interestingly, when we look at making sure that IVUS was properly used and interpreted, and we made sure the result was optimal, that even in this group here of optimal IVUS usage, where they got the best result using IVUS, rather than just putting the IVUS catheter in and perhaps not looking too carefully, there was an incremental result from using intravascular ultrasound there. And in the ultimate trial, you see in 1,500 patients exactly the same curves. So in all of this practice, in our general practice, intravascular ultrasound seems to be good. So why wouldn't I use it in the left main? Why would I put my head in the sand? Because ultimately the left main is special to everyone in this room. Why is the left main special? Well, because it supplies 2/3 of the heart's blood, at least. Because a lot of plaque goes to make that narrowing happen. It doesn't happen with a small amount of plaque, and that plaque can move, and when that plaque moves, and a lot of plaque moves, then there will be consequences. And if you lose a branch during left main intervention, there will be hemodynamic consequences. And importantly in this session, we recognize that most left main will involve calcification. And of course, most left main involves a bifurcation, and most left main will involve an interaction with the guide catheter, which makes it not unique, but challenging. So, which cases is it going to be difficult for me to guide my intervention with angiography alone, without imaging? In cases where there's calcification, in cases where there's overlap, in cases where there's bifurcation, and in cases where the guide catheter is going to interact with the lesion. All of these are the left main. And actually, we've known what to do with intravascular ultrasound for a long time. This data from Kang goes back 15 years. And we know that if you don't get a good result, particularly at the ostium of the circumflex, that the patient outcome will be poor. There's limited data in some of the randomized trials, if I'm honest, but there was some data from Excel where a minority of patients had intravascular ultrasound in that trial. And if you looked at the impact of IVUS-detected stent deformation, you see quite marked impact on clinical outcomes when the stent is deformed during the case. And notably, that information was available to the operator, but they chose not to do anything about it. So it's not just putting the IVUS catheter in that makes a difference. You have to look at the pictures, and you have to do something with the information. But for those skeptics out there about randomized trials, I don't believe in randomized trials. Show me what happens in the real world. Show me what's happening in Oxford today. Well, this is what was happening in Sweden. Registry data from their excellent registry in Sweden looking at the impact of intravascular ultrasound on left main intervention, and you see an impact on mortality. Patients living longer and better when IVUS is used. This data from China, a meta-analysis of IVUS in the left main, and you see an impact on all-cause death and cardiac death. And this data that comes from the UK, looking at improved survival rates using IVUS versus no IVUS in the BESIS registry. So there is data from the trials, there's data from the real world, and we hope soon to show you the data from a specialized, dedicated randomized trial, the optimal trial, which we're doing in the UK, in Spain and in Italy, and we're nearly 2/3 full. So we'll have that data, I hope, in about 2 years' time. So finally, what do you need to do with the IVUS when you do it? You need to think about space. How much space have I got and how much space do I need? You need to think about size. How big is the lesion that I need to, how big is the stent I need to get? And you need to be sure that there's enough length. Skill is important in left main, but only as important as space, size, and length. And skill means that you don't make a problem, for example, longitudinal deformation of the stent, and you can, with skill, prevent complications. But ultimately, if we use this guideline, then our procedures will be better and our patients will thank us. Thank you very much.
Thank you very much, Adrian, for this nice overview. Let me just quickly check here in the panel what is the attitude in terms of intravascular imaging usage in practice. How frequent do you use it, Darshan, and in which setting?
Yeah, so I am a heavy intravascular imaging user. So I think Adrian showed the IVUS XPL data. He also showed the ultimate data. There are other clinical trials, IVUS CTO, and there's a consistent message. The message is that there's a 50% reduction in MACE rates and or TLF. And so I think it behooves us to use it in probably one of the highest risk and most important anatomic subsets, which would be left main. So for me, I think it's sort of criminal that if you're not using intravascular imaging to guide your left main intervention just because the stakes are so high. Okay. The other part I was just going to mention briefly is just at this conference, the Rolex registry was presented, and it showed that in large format stenting, what you have is if you use IVUS, it led to an increased size of the stent you were going to use by 50%. And those patients that had the increased size also had a 50% reduction in outcomes compared to the rest of the population. So again, I say all the time.
So for you, left main PCI, IVUS is a must.
Correct.
For you, Valeria, in Rotterdam, where is IVUS a must?
Well, I think if we refer to registry and randomized control trial, we see still that the penetration of intravascular imaging is limited. But I have to say that we have now data, and we also learn from experience that IVUS guidance can really guide every steps of our procedure. So not only the pre-procedural planning, but peri-intervention and then post-stenting optimization.
Emma, if you have any questions there.
Currently, no, there is no question yet.
Okay.
So far, so good.
That's good. So I think we are ready to go to London and see the case they selected for us.
So we have a fantastic case for you today. This is a 60-year-old gentleman with a background of learning difficulties, hypertension and dyslipidemia. He presented with an out-of-hospital VF arrest, with a short downtime and a single shot to ROSC. His post-ROSC ECG demonstrated widespread lateral ischemia, and he underwent primary angioplasty to an obtuse marginal branch with a 2.5 by 12 mm drug-coated balloon. As you'll see, he has severe calcific multivessel bystander disease with left main stem involvement. His LV ejection fraction on echocardiogram is mildly impaired at 45 to 50%, and he was discussed at a multidisciplinary team meeting and was deemed not to be a surgical candidate following surgical review.
Good morning, welcome to St George's. Very pleased to host this case for PCR, along with my co-operator Claudia Cosgrove. Welcome Claudia, and Michelle Conley, our fellow. You just heard a case presentation from Michelle, so you've got the case context. Jason, if you wouldn't mind taking us through the angiogram, please. So this is an areocranial view. You can see first of all that there's widespread coronary disease, multivessel disease. Your eyes drawn to the apical LED, there's two high-grade lesions there, reasonable distal vessel beyond that. Then there's this long section of disease extending from the distal left main into a large diagonal branch, which also seems to have further osteal disease. You can see when there's no contrast in the vessel that there's calcium, particularly marked at the ostium of the LED and distal left main stem. There's further complexity in the proximal vessels, quite difficult to disentangle those, but you'll see from a caudal view that what you're seeing your top right is a ramus branch, and the branch is coming towards us is a first marginal which bifurcates off that ramus branch. You can see there's residual high-grade occlusive disease in the marginal branch. Just before this bifurcation, further high-grade disease and probably slightly reduced flow in that area. Again, suggestion of osteal disease at the ramus branch and further distal disease in the ramus branch. It's all quite crowded up there, so I think we're going to use intravascular imaging to try and just get real clarity around that. And then you've got the iliocaudal view. Here, it's pretty clear that the LED ostium's got further disease, and there's calcium extending from the left main into the LED and actually extending as far as the diagonal branch. And again, you've got this ramus branch, sort of rather funny little circuit into the ramus branch, which looks like there's some disease in there as well. So our current strategy, if you go back to the cranial view, is to treat this apical LED, probably with just balloon inflation only. We're going to then interrogate the lesion with IVUS, and Claudia is going to take us through those findings, and that's going to determine our strategy.
Okay, so James has just done some pre-dilatation of the LAD with a 2.5mm non-compliant balloon, and we were able to pass the IVUS catheter more distally now, and we can see that there is a nice normal disease-free landing zone distal to the diagonal with external elastic laminar measurements of about 3 millimetres. So that's looking like a nice distal landing zone. We can see, again, this area of concentric calcium here is disrupted. And coming up to that very tight proximal lesion, We can see actually there is a bit of disruption already just with the non-compliant balloon, but probably needs some further calcium modification there. We can have a talk about how we're going to treat that now.
Right. Actually, looking at this angiogram, I couldn't identify a single spot free of disease. As a matter of fact, it's not just a distal left main lesion. It's the whole left main LAD is diseased, the circumflex is diseased, the diagonal branches are involved. You know, if there is a low penetration of intravascular imaging, as we've heard from the previous discussion, means that this kind of case is currently being performed under angiographic guidance. There is no other way out. And I wonder what might be the risks we are running to do this kind of procedure purely under angiographic guidance. Now we can comment on this with hindsight and knowing what's inside the vessel. So who wants to start? Just pure angiographic guidance. What are the challenges we are taking, not doing with IVUS this procedure, Adrian?
So I guess the
Take
first
the microphone closer.
I guess the first thing I look at is you see the calcium and you decide, am I going to rotablate it? That's my first question. And it didn't look that bad. It didn't look too tight. But rotablation would be my first blind question. Now I've seen the imaging. You can see that actually the lumen is relatively preserved, although there are a couple of concentric areas. So I'm going to need something more than balloons. Lithotripsy is probably what I'm going to use. And the issue for me is that that big diagonal, I think, is important. It looks like it's the only diagonal. It looked like it bifurcated, so I'm going to try and look after that diagonal. And I wasn't sure about the ostium of the circ, whether that was severe or not. So I'm not going to worry too much about the circ, because I understand that perhaps the viability is less good. He's had an infarct there. So I'm mainly looking after the LAD, keep the diagonal open, keep the circ open, obviously. And I couldn't make a comment really about the intermediate. I wasn't quite sure about that.
Any additional comment, Darshan?
Yeah, so I think it's three things, right, that can go awry if you don't use intravascular imaging. First is whether or not you need to do any sort of real calcium modification. The second is the actual stent strategy. If you're going to do a two-stent strategy or a one-stent strategy based on the degree of plaque burden. And then the third is the sizing of your stents to make sure that they're appropriately expanded. And I think that you're, again, doing yourself and the patient a disjustice if you're not using intravascular imaging.
So really, in this case, is enhancing your diagnosing and already anticipating what are the next steps. And on this, I'd like to pick Valeria's opinion. We have seen the angiogram now. We have seen the IVUS. What can we do more? I mean, what did we learn from this additional information?
Well, I think what's important to stress out is that we could appreciate actually some calcium at the angio images, but that was not really a good estimation of the calcium. So we can really fully understand the calcium severity, and I speak in terms of calcium arc, extension of the calcium, and also calcium depth, only using imaging, and that's going to guide us further in choosing which kind of plaque modification technique we're going to use.
That's right. What is also interesting that it took just a little balloon dilatation. That's sufficient to get the IVUS guiding down to already cracking some of these calcified lesions there. And if I'm not wrong, I haven't seen a single spot with a true circumferential calcified ring. Is this already directing us towards the use of this or the other device, Adrian?
As I said, I think it means I probably would not use rotablation here. I think lithotripsy probably still is a likely option for me, because I think there are probably arcs of 375, nearly 360. So, as I said, I think I've got the lithotripsy machine ready and primed.
So, Darshan?
Yeah, so there's multiple different criteria to figure out if you're going to need some upfront form of calcium ablative therapy. So the The scoring system I use was published out of Columbia by Akiko Mahara and colleagues. It was published at the end of last year. And it looks at 4 specific things. 1, it looks if there's 360 degrees of calcium at any point. 2, if there's more than 270 degrees of calcium for more than 5 millimeters. 3, if there's an eccentric calcific nodule. Or 4, if the vessel size is less than 3.5 millimeters. And if you get 2 or more points, then you should think about using something here. I agree with Adrian. There's no 360 anywhere that you're seeing. You're seeing some degree of calcification that's really substantial. I think it's reasonable to start with a cutting balloon here and see how it goes, and if not, then upsized, and then potentially use atherectomy then.
I can tell you what most likely I would have done just looking at the angiogram, not looking at the IVUS. Of course, I would have already appreciated some degree of calcium. Perhaps I would have put one guide wire down and starting with a non-compliant balloon, really probing, palpating the plaque, see whether this lesion would open up. And if so, perhaps I could have skipped all this. And of course, IVUS has already informed me that there is much more than that, that perhaps we might need some more aggressive plaque modification. And I know that there are questions from the chat, Emanuele. I don't know if you can summarize the most relevant.
Mainly the first question is about the strategy to be decided upfront, even before the PCI. So is the question why this patient could not be referred for CABG? And the second is, in case you will decide for an AVL, for which size of balloon would you go for?
Yeah, this is actually an important question. I guess as to the indication to bypass surgery, this has been discussed locally by the colleagues. This was a patient brought in with out-of-hospital cardiac arrest, has been intervened upon on the circumflex. So it's not the kind of patients that cardiac surgeons would like to operate right away, at least at my place. But certainly the questions on the sizing of the plaque modification devices based on IVUS, now that we've got this information, is certainly a valuable one. Valeria, in your practice, you have this IVUS information. If you have to use IVL, what are the key informations you would extract from IVUS to guide your the shockwave balloon size selection?
Well, what's important to consider is that you have to aim for a 1-to-1 ratio, so 1-to-1 balloon size and diameter you want to achieve. So if you don't have really a good estimation of the actual size of the vessel, you are going to undersize your IVL balloon. You're likely to undersize your IVL balloon.
But let's try to gather some consensus. If I can summarize, I think there's quite of a consensus that after having seen this, perhaps this is not the right indication for rotational atherectomy. That's number 1. Number 2, we are still left open whether this is the right indication for IVL, yes or no. Any thoughts here? Just yes, no. IVL?
Yes for me.
Yes for you?
Yes, it seems reasonable.
Yes for you as well. There might be other opinion here that might have looked also at the thickness of the calcium, which is of course something we cannot fully address with this technique. And cutting balloon, scoring balloon, that's also a good option, of course, given the fact that this calcium seems to be quite superficial, so we can certainly tackle that efficiently. Did we forget anything?
The other thing I want to do is now I've got the imaging, I need to plan where my stents are going to be, particularly relevant to where the main branches are. I don't want to be ending up with a stent near ending either at the ostium of the cert or at the ostium of that diagonal. So I need to think about what that segment of disease is, and I need to be visualizing where my stents are going to end, how many stents I'm going to need, how I deal with the fact that perhaps it's going to be 4.5 in the left main, and it may be as small as 3 at the other end. How do I break that up in my mind? How many stents am I going to do? So I need to be visualizing the intervention, which I think is something we can do with imaging, which we tend not to do with angiograms, where we put up the balloon seems to go up, we put our first stent in, that seems to be okay, all right, I'm in. But we're not really thinking about what I'm going to do to get the best result. We're just kind of in and running. And I think we do need to, and it's something I think that intervention perhaps learns from TAVI. You know, we're planning more, and we need to plan. We need to think, to visualize what the lesion is, to how we're going to get the best result.
What you're saying is particularly important, especially because here the risk is that we end up with full metal jacket. So it's key to understand where is the starting point, but it's extremely important to understand and to know upfront where are we ending this stenting procedure, which is equally important. Why don't we go back to London and see what they decided to do? Oh, it jumped immediately. This is next one. This one.
And if you're looking to choose what calcium modification in this situation is probably depth, you know, the cutoff from the research is about 0.75 millimeters. That cutting balloon adds value over NC balloon at 0.5 to 0.75. Beyond 0.75, when you get into 1 millimeter, you're thinking about lithotripsy for concentric modification. So I think it's probably reasonable to do cutting balloon modification here and then recheck that. Okay, not that far. Right, go on. Okay, back to the big screen, thanks. What do you have? Huh? 16. What are you at, 16? Go down. Okay.
All right, so coming back, just looking at the proximal LAD after dilatation of a cutting balloon. I think that was our area of concentric calcium that we just passed, and we can see that it's well and truly disrupted now. We're back into the left main already there now.
There you go. I mean, that's a dramatic difference, isn't it, Claudia,
between... Stop there,
we can go back and look at that. At the ostium particularly, whereas the concentric calcium, we were really wondering, was it modified?
Look at that. I mean, that was our ring of calcium.
Yeah.
It's all, and we can see, you know, it's
so there's no question it's been modified now.
That's actually great. I have two key points that I would like my colleagues here helping me clarifying. Number one is how to best use this incredible tool, how to best use the cutting balloon. What is the best indication for it, whether there is perhaps an indication where the device is less optimal. Who would like to kick off and share his own experience on this specific question?
Yeah, so I think, first of all, there are different types of cutting balloons. Despite the fact that this is a Boston Sci sponsored session, the Wolverine, I think, is amongst one of the best. There's a couple of reasons why, but let me answer the question that you posed. So I think that James brought up the fact that it depends on the thickness of calcium. So if you use something like OCT, you can actually get true thickness and then make a determination. So if it's less than 1 millimeter thick, the cutting balloon will be effective. The second is if you are going to use it, you do want a balloon that is fairly compliant but has multiple blades. So there are different products on the market, and the Wolverine tends to expand exceptionally well, although it has a limit of 12 atmospheres. I size it 1-to-1 and making sure that every part opens up appropriately.
That's a good point. Is there any specific setting where you would not recommend cutting balloon? I'd like to pick your thoughts about calcified nodule. I mean, is this a good way to go, or what are your thoughts?
Yeah, so for calcified nodules, I think we still don't have a great answer as to what the best modality is, because there are different types of calcified nodules, some of which will actually, you can actually do some cutting and actually allow for expansion. Other types, the calcium nodule will just get pushed out and you really haven't done anything. So I think that's still an area of ongoing research, and I think it's still a pain point for all of us.
Let me just inquire here in the room, how many of you do use regularly cutting balloon? Please raise your hand, please. About 50% of the colleagues. There's another 50% of the colleagues who do not use it. Is there any one of you who would like just to explain how are they done and how to best use them? I mean, really practically, how to inflate them, how to position them? Perhaps Valeria?
Yeah, that's a really good point. I think there are different ways. Probably we could achieve the best result actually inflating the cutting balloon really slowly, so 2 by 2, and that's the best way of unfolding the blades of the cutting balloon. And we have, in this regard, a question from the audience, if we can reuse the same cutting balloon for multiple lesions?
Well, I suppose so. Yes, we can. Of course, another point is due to the fact that the crossing profile of these balloons is not exactly the same as the one of semi-compliant or non-compliant balloon. And of course, I suspect once you use this balloon once, their crossing profile cannot certainly improve thereafter. Nevertheless, at least as far as I'm concerned, I like to use them very much, especially when the lesion is rather proximal, located in large vessels, while we might have a little bit more difficulty in advancing them in distal tortuous vessel. I don't know, what is your experience, Adrian?
Yeah, I have to say I don't use a lot for cutting balloons. I think you're right that they're good in the proximal vessel, and the nice thing about them is they're accurate. They stay where they want to be, and they're not as you put them up, because actually that is the real hazard in calcific disease, that you end up then extending or dissecting or doing high pressure in an area which you didn't really mean to be in. So I think that's a real benefit of cutting balloons. But my use is quite small. And certainly for critical disease, I never start with them. If I think rotablation, it's rotablation. And I'll do that first and then see where I am.
Yeah. Well, stay on that, because there is another specific indications where cutting balloon is great. How about in stent stenosis?
Exactly for that reason about the pipping.
The pipping, I like
in
this.
in-stent restenosis, it will always pip, because the character of the nature of neo-intima, assuming this is in-stent restenosis, not a badly deployed stent, if it's neo-intima, then a normal balloon will almost always pip. And the only way you fix it is to use a balloon that's too long on either end, and therefore you then end up putting a much longer stent in. So a cutting balloon is a good idea for in-stent restenosis.
Emanuele, do we have questions?
Yes, these are mainly technical questions related to the use of the cutting balloon. First one, people are asking what's the difference between cutting and scoring, and whether you would choose one or another.
Or the other.
And the second question, if may I, is if can you use the cutting balloon for bifurcation PCI if you have the wire in the cell bench?
Who wants to take the first question? You want to take the second question?
Second question is yes.
Okay. So the second, who wants to take the first one? Cutting versus scoring?
I never use scoring.
Yeah, I don't use scoring either.
Well, what I can say myself is that I find that scoring balloon have slightly better profile. So if I have to use them, especially in more distal vessel, in tortuous anatomy, perhaps that would be my preference. That's, I think, the best answer I can give you on that. Let's move on next to the image that we've got after cutting balloon. I want to, again, pick your experience on image interpretation. We have seen James Pratt quite satisfied about the result of plaque modification. What do we need to see on the IVUS image to say I'm satisfied with plaque modification? Let me start again from Adrian.
Well, I guess I assume he's planning to implant a stent here, and therefore he needs to be sure that he has disrupted the plaque sufficiently that a stent is possible. And that means really that you haven't got an arc of 270 plus still, that the maximum arc is 180. You certainly don't want any more than that. So you want to see that there is lumen, you want to see there's free space. One has to recognize that when you expand a stent in the image that's there, that arc from 12 till 6, the stent will not expand very much in that area. That's just going to be fixed. And so all of your expansion is going to be between 6 and 11. That's the area of the vessel you can now dilate. Because we are not magicians. You can only do what you can do. And but you need to see that you've created some space that you can make it. The objective is to make the lesion safer with a stent in, not to increase the risk by putting a small stent in that is too small and cannot be properly expanded.
I fully agree with you. In this kind of setting, really the stenting should be really the last step of our procedure. And we should get there really when we are absolutely sure that our stent will fully dilate, well oppose, and expand properly. So I think we are heading to the next step of the procedure. We modified the plaque. We need to decide now which stent and which size and length of the stent. So, and we asked these specific questions to Darshan, who prepared, I think, a set of slides for us. And the specific question to him was, what should be the ideal feature of a stent for this kind of challenging lesion setting? And what is the stenting technique that we need to use?
All right, thank you. So here are my quick disclosures. So one of the things I was asked is when you have a true bifurcation, particularly in the left main, which is not infrequently encountered, what is the optimal stenting strategy? Do you go with a one stent strategy that's provisional, or do you go with a two stent strategy? So I want to give you a thought framework that I utilize for making that decision. This is actually not my own algorithm. It's an algorithm developed by Dr. Jeffrey Moses at St. Francis. And the way he decided to categorize whether or not to perform bifurcation stenting in a left main is with the following. So one, the first question is it a true bifurcation? So a true bifurcation is a Medina 111 or a 011. If it's not, then you can just provisionally side branch stent if you have to, if there's an issue. Now, if it is a true bifurcation, the next question is the side branch suitable for stenting? So if a patient had an infarct in that area and that area isn't viable, then you're really not going to stent. If it's a very small vessel, a 2.0 or less, and you have a very dominant right coronary, then perhaps you won't go ahead and stent. Now, the next question after that is the side branch disease diffuse and or is it not located within 3 millimeters of the ostium? If the answer is no, then provisionally stent, and if it is, then electively implant 2 stents up front with a main branch and a side branch stent. Now, a lot of this is actually informed by clinical trials. So this isn't just a general gestalt, but there's data to back this up. So one of the trials I want to mention is the European Bifurcation Club left main trial. It was actually published in the European Heart Journal 1 day to the date, 1 year to the date today. And what it was a trial where 467 patients were randomized in a 1-to-1 fashion at 31 centers in Europe. And they were randomized to either provisional stenting or to upfront 2-stent strategy if they had a true bifurcation. Again, Medina 111 or 011. Now, in the provisional strategy, it's important to describe how this was done because not everyone might be doing the same provisional strategy. So the provisional strategy here was pre-specified. So you had to have wires down the LAD and into the circ. You wouldn't pre-dilate your side branch. It was generally kind of recommended not to do it. Then you would take care of your main branch. You would stent it, recross into the side branch, do a pot, and then do kissing balloon inflations. Now, the only time you would have a bailout stent strategy is if one of the following things happened. One, if there was an osteostenosis that was greater than 90%. 2, if there was less than 10-3 flow. 3, if there was abrupt vessel closure. Or 4, there was a dissection that was fairly substantial. Otherwise, you did not stent into the side branch. Now, in the upfront 2-stent strategy, the stenting strategy was left at the discretion of the operators. So the 4 most commonly used were the DK crush, the culotte, TN protrusion, and just the T. All right, and so the primary endpoint was a composite of death, MI, and revascularization at 1 year, and there was no statistical difference. And if you looked at the individual endpoints of death, MI, and revascularization, again, no statistical difference. They also looked at stent thrombosis, no statistical difference. But if you use the provisional strategy, what you did find was, 1, that there was less usage of radiation. You also found that the procedures were shorter, and 3, you had less consumables used. So basically, it was a more efficient process if you use a provisional stenting strategy versus if you didn't. Now, the main drawback of the EBC main was the fact that this trial did not pre-specify the 2-stent strategy. So the DK crush strategy, which has been shown in other trials to potentially be superior as a 2-stent strategy, was used in about 5% of cases. And in the pre-specified arm, 6% of patients actually never got a second stent, even though they were supposed to. So it doesn't tell you if you are going to go with a 2-stent strategy what the best 2-stent strategy is. And that data really comes from the DK crush study. So the DK crush 3 study basically looked at MACE rate and found that DK compared to culotte was associated with a higher MACE-free survival. And then DK Crush 5, as well as Definition 2, specifically looked at DK Crush versus provisional stenting and found that, again, DK Crush was lower for TLF. Now, the problem with the DK Crush is it is somewhat operator dependent. In order to be considered for the DK Crush 5 trial, you needed to have done 300 cases per year, PCI cases per year for 5 years, and over 20 left mains per year. That was the only way you were going to be part of the trial, which probably won't apply to the vast majority of interventionalists out there. So with that being said, I think the data really points to a provisional approach, and if you are going to go with a two-stent strategy, then you should probably use a DK Crush strategy. Now, the other part is what type of stent to use. So the Excel sub-study, so again, the vast majority of patients in Excel did not undergo IVUS-guided PCI, which again, as I said earlier, I think it was a travesty. But what it did show in the people that underwent IVUS guidance was that there was a decent amount of stent deformation. The areas that you would expect would be deformed were the ones that were most likely deformed. So the left main ostium, particularly if the guide was kind of ramming into and out of the ostium, was nearly 80% of where the deformation was. The left main shaft followed suit, and then subsequently the LAD. Now, Adrian already showed this. In those patients that had left main related deformation, you basically had more than a doubling of your MACE rate. So the key takeaway here is that you clearly have an issue when the strength of the left main is compromised. So what type of stents to use? Again, this is a Boston-sponsored talk, but this is not. This is something that I genuinely believe in. So you're going to use a stent that probably has the greatest radial strength as well as axial strength. And on bench testing, that seems to be the Synergy Megatron. The one caveat to that is that the vessel has to be 3.5 millimeters or greater, otherwise it won't work. So I'll stop right there. Thank you so much. Sorry, I'll go back.
Thank you very much, Darshan. Let me just inquire in the room, who has experience with the Megatron drug-eluting stent? Please raise your hand. Okay. Can you just, that's a great stent. Honestly, each time I treat, and again, I truly believe that this is a great stent for left main stenosis. It offers different possibility. Can we highlight what are the key reasons why this is the greatest stent for left main? I don't know who wants to, Darshan.
Yeah, I can take it. So there's a couple of reasons. The first is one, obviously showed both the radial and the axial strength.
Yeah.
Two, there is less.
Sorry, I want to pick your brain on this radial strength. Why is it key in a left main?
Oh, I'm sorry. Yeah. So one of the issues that, as you saw from the Excel data, is that there can be stent deformation, whether it's due to the guide or whether it's due to the fact that you haven't. There's some recoil of the stent. So you want that radial strength to really make sure that your stent stays optimally expanded. So when the patient leaves the table, it's exactly as you intended the stent to be. And when you have a kind of a heavy duty stent like that, the likelihood of having recoil or deformation is markedly lower.
Valeria?
Yeah, I just wanted to point out how important it is to have good radial strength, particularly at the proximal part of the stent. So actually the Megatron has extra connectors. It's a really particular platform, stent platform, which has extra connectors in the proximal part. So actually avoiding any problem with longitudinal deformation, longitudinal compression that we may actually cause with catheter engagement. But on the other hand, these extra connectors are not present in the distal part of the stent, where we may have anyhow good access to the side branch ostium. So that's why it's really tailored to the left main anatomy.
And the size matrix, of course, and the flexibility of the size matrix. That with even if you start off with a 3.5, you can take it up to way beyond 5.
Yeah.
And it also that the opacity is helpful, particularly in heavily calcified vessels. You can really see where the stent is, and you need to see where the stent is because you're going to need to be interacting with the left main ostium. So those aspects of that stent are also very important, I think, for the left main.
Emanuele, any question for the time being?
No, so far they're just remarking that it's a very valuable stent for the left main, and they ask you whether you will consider any other stent for the left main, and which one eventually, if you don't have the Megatron?
Well, let's first go back to London, and then we'll take this question right after.
Yes, and what about stent sizing, Claudia? What did you think about stent sizing and stent selection?
The length from there to the ostium of the LID is 38 millimetres, with a distal reference diameter of nearly 3 millimetres. So that's just back to the ostium of the LAD. We're going to need to extend further back into the left main. So I think we're looking at 2 stents here, more distal being a 3.0 platform and more proximal a 3.5 platform that can expand up to the diameter of the left main, which we saw here was about 4.04.
Okay, so 3028, reasonable to start with?
Yeah, I think that's fine.
Let's take that then. So this is a dual lumen catheter, Sasuke, which we're using to help access the side branch.
Covering the ostium?
Yeah, I think so, yeah.
Inflating.
This is the diameter of the side branch.
Start o'clock. And you've got the 3.5 non apart.
Can I go there?
Yep. So you can see. Inflating.
Up 3, 1, 2, 3.
Down from 10 in both.
The 4 or 5 pop balloon in the left main. Yeah.
Inflating.
Bring it back a little bit. Well, it seems to cover the stent, doesn't it? It really expands a bit.
I mean, we know the stent's well expanded, it's just to get a better lumen.
Bit of volume, yeah. Okay, great.
Okay, down from 12.
That's it.
That is.
Happened there.
Okay, inflating. And brains. I think that was our osteal LAD, was it?
Yeah, I think that was the ostium. You see that there's the branch we've done, which looks okay.
It looked okay on there, didn't it? So left main looks really well expanded the whole way. It was the distal bit that was most of it. Oh, there we go.
That looks fine, doesn't it?
Yeah, it was landing nicely. Just
Okay, in summary, gentleman who was turned down for surgical revascularization, complex left main procedure involving 2 bifurcation and a lot of distal disease, 2 stents from mid-LAD back to left main, recrossed into first diagonal branch using a dual lumen catheter, drug-eluting balloon, kissing balloon to the LAD D1. Then, with some complexity, rewiring the ramus branch again with the dual lumen catheter and drug-eluting balloon to the ramus branch over a long section of disease in a small vessel again. Finished with a pot to the proximal left main. MSA in the left main is 13.5. MSA in the proximal osteal LAD is nearly 10, 9.76. There's some residual disease, dissection seen in the ramus branch, but with brisk flow, which will allow that to heal. I think we felt the discrepancy in terms of size was difficult to implant a long, small stent. Coming back into left main, we'd have to crush that, and we were concerned about the durability of that. There's some residual distal disease in the distal LAD, which has also had a drug-eluting balloon. So the gentleman's going to need follow-up angiogram just to make sure everything's healed up, but he's tolerated the procedure very well, and I think it's been a good demonstration of calcium modification and complex to two vessel, the two bifurcations. So big thanks to Claudia and Michelle and John Hung for supporting and the team at St. George's, and we'll hand you back to Paris.
And of course, a big thank to the team in St. George's to have shared this very nice case. I think there is still some work to be done here. We need to discuss a bit on several tools we have actually seen during this last bit of the case. Well, let me start first from this dual lumen catheter. It's an interesting one. Any experience here in the panel?
Yeah, so the Sasuke is what James used. So it's a dual lumen microcatheter that is around 140 centimeters long. It has a very low profile. It's very similar to kind of a Corsair in the proximal portion, though it's not a torquable catheter. And it works well. So it's predominantly used for side branch access, but also used for CTO PCI. And there are other competitors out there, but the Sasuke is actually very nice and slick.
So the reason they're doing it is to remove the chance of being behind the stent with that second wire. Now, one of the great things about PCI is we all have opinion, and sometimes there are things we all agree on, and other times there are things none of us agree on. I would have had a wire in that diagonal, personally. Yeah. For my first stent, and then I'm going to put the wire back into the circle. I might have used 3 wires, but I'd have had a wire in the diagonal all the way through personally, just so you can mark it. And there's some sense, I think, that perhaps they help keep it open, but probably the most important thing is it just marks it.
Then there is a second aspect I'd like to discuss. We never end actually a stenting procedure in such a calcified lesion setting just with stenting. We always tend to do some additional post-dilatation. And there might be opinions there on what is the kind of best balloon to use to post-dilate stenting in this kind of setting. Any preference here? We heard they use non-compliant balloons. I don't know if we have different attitude here in the panel. Valeria, perhaps?
Yeah, I do agree with non-compliant balloon. I think what's important that you have to check your final result after that. So you actually achieve the best stent optimization.
We'll come back on this. It's a very important aspect because it doesn't just need that you guide your stenting selection. You need to assess what is the result. The IVUS catheter is open. Of course, you open it up again. Any room for a higher pressure balloon here to optimize the stent, or non-compliant balloon is enough?
Well, you're guided by the IVUS. But I think the other comment we probably haven't made, which is important, I think, is that the safest result is for the the safest result for left main bifurcation is a single stent. If we can avoid the double stent, we should, and we must always avoid a double stent if we don't expand those stents properly. So, once you reach for the second stent, you're now into sequential pot and kissing. What you can't do is to use the second stent and not do it properly. I think, to be honest, when we look at the data for DK crush, its great strength, its great weakness is it is prescriptive. You do this, 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 but you will always have to put 2 stents in. That's kind of what, but you have a clear recipe and you follow the recipe. And if you do enough of them, then you get good at it. With provisional, it is a layered approach, and it, many times, 80% in the EBC left main, you get away with 1 stent. And that 1 stent, properly deployed, is the safest outcome.
We heard to check the final stent result, but what is the result we are aiming at with IVUS? Is there anyone who wants to explain me what are the key parameters we are looking at when optimizing the stent and checking the stent?
So the Kang data, 5, 6, 7, 8, I think probably is a minimum. I think there's been debate about whether those standards are stringent enough for a European population, but you certainly, absolutely, particularly if you use 2 stents, must achieve 5 as a minimum at the ostomy of the circ, and 6, 7, 8 is easy to remember. But generally, I think these days, we would probably think that's too small, and we should be aiming for 10, if we can, in the Prox LAD and beyond in the left main.
And that's been borne out by the Excel IVUS sub-study data as well. So you definitely want to go larger. So the 5, 6, 7, 8 is just a bare minimum. You want to go as large as humanly possible without, obviously, getting a perforation.
We still have a couple of issues to clarify and questions to address. For sure, we will address the question on the type of stent. I mean, some of you were concerned we don't have the Megatron stent. How do we manage? What is your proposal? We'll tell you at the end of the session. So stay with us. We'll address this question. Drug-eluting balloon. They were used a couple of times in this case. It was used for the distal LED, and it was used also for this ramus branch. Any experience here in the panel with drug-eluting balloon in distal branches, in bifurcation, in place of plain kissing balloon or double stenting technique?
I can just mention this very quickly. Unfortunately, in the US, we do not have drug-coated balloons or DEBs. As of yet, they're just investigational, so unfortunately, I have no experience.
Adrian?
Yeah, I mean, I use them, but in the context of the acute result, it's just a balloon. And the drug element protects you in 3 months' time. So this is a non-compliant balloon deployed carefully with scrupulous assessment of the angiographic result. There's no magic in the paclitaxel or the sirolimus that makes a difference to whether that vessel is going to stay open at 1 hour or 12 hours or 24 hours. So it's going back to using balloon angioplasty essentially in the skills that we had then. I think one of the difficult things using drug-eluting balloon and OCT is you wonder a little whether I really want to see all that. Back when we did balloon angioplasty, you didn't see all this dissection and stuff, and we have to train ourselves a little bit to kind of not be too addicted to stent-like results and to trust our angiographic assessment and learn what we can leave on OCT and what we can't necessarily leave safely on OCT. And I'm still struggling with that a little, partly because I use mainly IVUS. So.
Valeria.
Yeah, I want to echo actually Adrian about the main concern, because then if you use a drug-eluting balloon and then you have a dissection, what is going to be your next step? A major dissection, I mean. But I think, the way I use it, and I think there's a big potential for drug-eluting balloon in a side branch dilatation. I think the way I use it is that I prepare the lesion with a different kind of balloon, really remaining at low pressure, and then drug-eluting balloon can be also used in a final kissing inflation, because in this way you can restore the anatomy and the architecture of the bifurcation, but you always have to complete this procedure with a final pot, as we know also from the EBC trial.
That's also a good point, and I'd like to just emphasize this decision the colleagues from the St. George's Hospital took to leave this dissection untreated with stent. The flow was good. They left it like this, and I tend to agree. Instead of getting there and implanting a stent and perhaps expose these patients to higher risk of stenosis, perhaps it was the wise decision to take. I don't know what you think about this. If there is any concern that this vessel would occlude or...
Well, we have to remind ourselves of what we learned 10 years ago, before stents. Longer than that, isn't it? 20 years. When I had hair. You can leave dissection as long as flow is good, and you're patient. You have to watch it for a while. You can't just take one picture and then pull the sheath. You have to wait, and you have to be sure that the flow is good, and then you make your decision.
Okay, so I think we are almost heading to the end. Let me just share this slide, and then I give you my final answer regarding the stent. Let's see if it goes on. There we go. Here I highlighted what, according to us, are the key important points about what we've discussed today. First, intravascular imaging is key for accurate characterization of left main stenosis to guide the most suitable plaque modification tools and techniques. And we have discussed many of those. And to guide appropriate stent selection. Cutting balloon is an effective and safe treatment for superficial non-concentric calcified lesions. We had a beautiful example in this case from London. And finally, Megatron stent enables optimal treatment of left main calcified stenosis, warranting good access to the side branch. And just to tell you how seriously took your question, I did a quick poll here among the colleagues who didn't have Megatron stent in their cath lab and in their shelf. And actually, I didn't manage to find any other stent for this kind of indication. So the best advice I can give you, there must be Boston reps here in the room. Just take their card and you fix this problem. Thank you very much.